This is our third and final lecture of the upper extremity. In the first lecture, we went over dysfunctions of the shoulder area. In the second one, we talked about the sits muscles. And in this lecture, we're going to talk about the carrying angle, the radial head, and some counter strain points that you'll notice in the forearm. So we're going to start off with the carrying angle. So what is the carrying angle? Imagine that you are standing up straight and there is a heavy weight on the ground, or a pail of water, or a backpack, or whatever. When you pick up that weight, the angle that your arm is located is going to be the carrying angle. So to draw this out and how we calculate the carrying angle, we're going to have a few different axes of motion. So you have your humerus, your radius, and your ulna. So there's two axes that you use to calculate the carrying angle. I'm going to use a humeral axis, which runs directly down the shaft of the humerus. And then you are going to use the forearm axis, which is going to run between the radius and the ulna back towards the elbow. The carrying angle is going to be this angle here. In men, this angle is typically smaller than in women. In men, the typical angle is 5. In women, the typical angle is about 10. Usually you have plus or minus 2 degrees. So why are we talking about the carrying angle? So you can have two different types of carrying angle extremes. You can have cubitus valgus, and you can have cubitus varus. So when we go over cubitus valgus first, imagine that someone's carrying a big weight, and instead of having their arm straight, their arm is going to look like a big L, cubitus valgus. So their elbow is going to be close to their body, and their wrist is going to be a little bit further out. So this is what we call cubitus valgus. So writing that out, cubitus valgus looks like a big L, and it has an L in the name of it. This carrying angle is going to be greater than 15 degrees. And there are two landmarks that you need to know where they're located with this carrying angle. Imagine you have your arm in the shape of an L, and you notice where your ulna and your wrist are deviated. Your ulna is abducted, it's further away from your body, and your wrist is pointed towards you, so it's adducted. So they're both opposite. Your ulna is abducted, and your wrist is adducted. So writing this out, you have an abducted ulna and an adducted wrist. So the first type of carrying angle extreme that you can have is cubitus valgus. So what's cubitus varus? It's going to be the opposite. So instead of having a big L angle, you're going to be kind of cattywampus like this, where your elbow is further out and your wrist is really close to your body. The main difference that you need to see here is that your ulna is now adducted, it's closer to you, it's adducted, and your wrist is now pointed away from your body, so it's abducted, abducted. So writing that whole thing out, we have cubitus varus, the carrying angle that you're looking for is less than 3 degrees, you're going to have a adducted ulna and an abducted wrist. Don't worry about being able to fix the angle right now. Really, you're going to be asked to diagnose the carrying angle and understand where the landmarks are for each diagnosis. So we're going to leave the carrying angle behind and we're going to start talking about the radial head. So the radial head is the head of the radial bone. So it moves when you are supinating and pronating your arm. When your arm goes into supination, your radial head goes anteriorly. When you pronate, your radial head goes posteriorly. So writing that out, pronate equals posterior. And supinate goes anterior. So remember, we always name a dysfunction based on what it can do. So when we go through these examples, think about where the radial head likes to go during motion. So imagine that you fall forward onto an outstretched hand. When you fall forward, you're going to pronate your hand to catch yourself. And when you pronate your hand, your radial head is already posterior. Well, imagine when you do that motion, you're then going to jam your radial head where it currently is. So it's going to get stuck posterior. So you're going to have a posterior radial head dysfunction. So writing out the example, fall forward, pronated catch, and a posterior dysfunction. So what about an anterior radial head? It's going to be the exact opposite. Imagine you fall backward. You're still going to try and catch yourself with your hand, but your hand is going to be supinated. When you supinate your hand, your radial head's anterior, and it's going to jam it further anterior. That's where it likes to go. That's the name of the diagnosis. So writing it out, fall backward, supinated catch, anterior dysfunction. So how do we make this diagnosis in a patient? What we're going to do is we're going to have the patient seated. We're going to have both of his arms flex at 90 degrees, and then we're going to passively assess pronation and supination. Passively pronate, then passively supinate. We're going to measure which one doesn't want to go in a certain direction in order to make our diagnosis. But remember, name the diagnosis on what it can do. So to make the diagnosis, we are going to passively move. So how are we going to treat these dysfunctions? We're going to use muscle energy for this. And the reason is it's easy to set up a barrier and it's easy to give an isometric contraction. Both treatments are very similar to one another, but the barrier that you engage and the isometric force direction are going to be opposite to one another. So remember, all the way back at the beginning when we talked about what does muscle energy mean? You passively engage the barrier. You ask the patient to then move into the freedom of what they can do, move further into the restrictive barrier, and so on and so forth. Same concept, different barriers. So for a posterior dysfunction, what's the barrier going to be? It's what they cannot do. If it's a posterior dysfunction, they cannot supinate. So the barrier that you're going to engage is a supination barrier. And then what direction are you going to ask the patient to isometrically move? What they can do, into the freedom, so they can pronate. So if it's a posterior dysfunction, your barrier is supination, your isometric force is into pronation. It's going to be backwards for supination. So if it's a supinated dysfunction, the barrier that you're going to engage is pronation, and the isometric force direction into the freedom will be supination. After your treatment, make sure that you bring the patient back to neutral and rescreen. So this is all for the treatment. Diagnosis, barrier, freedom. Diagnosis, barrier, freedom. So to finish out upper extremity, we're going to go over some common counterstrain points that you're going to see. And there are 3 big ones that we're going to go over. The first one is going to be the long head of the bicep. I bet I know what you're thinking. I already know how to do the treatment. I put them into the passive position, the position of ease. I bring the muscle ends together. You're exactly right. So to do this treatment, we're going to have the patient flex, abduct, and internally rotate. These 3 motions together bring the attachment and origin closer together for your treatment. The next position that we're going to talk about is medial epicondylitis. So medial epicondylitis is located on your medial epicondyle. All the muscles that attach to this are your forearm flexors. This is also known as golfer's elbow. So if all the forearm flexors attach to that location, what do you think the counterstrain position is going to be? Flexion. You're going to shorten the muscles. So you're going to flex the forearm. Pronate and adduction. The final one that we're going to talk about is the opposite of medial epicondylitis. It's lateral epicondylitis. It is called tennis elbow. The way that you can think about this is all the extensors of the forearm attached to that spot. Your treatment setup is going to be the exact opposite of the flexors. So just extend everything. So we have lateral epicondylitis. And you're just going to do everything backwards. So you're going to extend, supinate, and abduct. So we went over the treatment positions, but make sure that you don't forget the exact steps that you have to follow for counterstrain. You find the tender point. You make it a 10 out of 10 on the pain scale. Passively move them into the position. Make sure it's less than 3 on the pain scale. Hold for 90 seconds, passively return to neutral, and rescreen. You got to know all of the positions, but you also have to remember the steps. So in this lecture, we went over 3 broad topics. We went over the carrying angle, how to calculate the angle and the 2 different diagnoses you can have. We went over radial head, pronation and supination, and some common falls that you're going to be asked about, along with the treatment positions, and finally wrapped up with some counterstrain. And that's OMM for the forearm.